Welcome everyone to the third IPNFA Online Congress Live. We are very happy to be here today with you guys. And I'm Monica Cilento, the current president of the IPNFA. And here with me, we have all the speakers from this online Congress. So that's Carson Schaefer, Jamie O'Connell, Marcel Gebellas, Fritz Westerholt, and Benedict Bimmer. And we are happy to be here today to answer some of the questions that we've got from the emails. And the ones we are not going to answer today, perhaps you're going to have an answer by email because there are a lot of questions. So I hope you enjoy. And also we have a backup, our instructor, Leandro Giacometti, on our chat on YouTube. So he's also answering some small questions and helping us with all these tricky questions or doubts that you can have while we answering the formal questions that we have here. So I hope you enjoy, and let's start then, okay? On your right-hand side also, you can see a carry code. And if you click there, you go direct to the contact people in your country if you have any questions about courses and annual meetings and everything, okay? I hope you enjoy. Thank you for your attention. So dear Karsten, we have the first question for you. So it says, for a factory worker, they need to work nonstop for 2 hours. Repeated sustained reaching posture is needed for them to pick up items from the moving belt into their tray. They would have thoracic back region pain, especially the dominant side. What should we teach them?
Mm-hmm. Okay, first of all, thank you very much for this, watching our videos and for the interest to this question. Of course, I think we first need to reconfirm the hypothesis that the that the pain really comes from these structures that you thought of. And of course, it's always a good idea to show the patient some exercises, what he can do during the work. And for that, maybe we can prepare it in treatment. So in order to balance, let's say, the workload of the muscles of the mentioned case on these belt workers, it would make sense to do some repetitive movements during the work, and you can prepare that, of course, with some lifting, so PNF pattern lifting to the opposite movement direction. That would ease a little bit the joints and also stretch the muscles in the opposite direction. And I also can think of that you do some resistive work into the direction of the movement, but of course then with the idea of reciprocal inhibition. So if you go for chopping against resistance, you make a kind of relaxing the extensors that are working all the time. I can think of that makes sense to get some relaxation of the painful extensors. Other ideas of you guys? Jamie? Benedict?
Thank you for the answer. Because it's a bit difficult if you don't have to see the patient directly.
Of course, yeah.
This is the reason I think it's a good answer.
Okay. Thank you, Karsten. So let's move to Marcel. One question to Marcel. And so a person said, I can definitely see the changes about the hemiparesis example that you have in your lecture in the patient's gait after the treatment. However, one thing I'm not noting is that the patient is still hyperextending his right knee during terminal stance when advancing his left leg forward. even though the left step length is greater in post-test compared to pre-test. How do you address this?
Okay, so probably the reason for this hyperextension is that, or one possible reason is that the flexibility of the gastroc is not good enough. So of course, in the treatment I showed, I was doing some stretching, but of course, when we think about the last part of the stance phase, mid stance, terminal stance, he does not really have in a normal way. But anyhow, so at the end of the stance phase, there is the maximum elongation of the gastroc. And of course, maybe we still have some potential for the flexibility. So that is one thing. Then we can go back and do some more stretching, elongation, working in this lengthen range. Or if the potential flexibility is already achieved, then we have to live with that. So that is basically the thing. So when I get to the limit, to the beginning of the contracture of the muscle, and I cannot change that, at least not on short-term measurements, then we have to live with that. And so the question is pointing at, should I adapt the whole movement pattern to this limitation, or should I just tolerate it? And basically, I would prefer the patient to take this. So my personal view is that he is continuing to take this bigger steps and maybe a little bit asymmetric in order to be faster than making an artificial short step with the other leg. So that is my personal opinion. Maybe some others see it differently, but that's how I would handle it. As soon as the patient is not in the therapy anymore, he will walk as he wants to walk. So we should be aware that, of course, we can tell him, you have to do this and that, but probably daily life will challenge the system in a way that he is moving what is available. So maybe, I don't know, Benedict, would you see this in a different way?
No, for me, I thought it was really a good improvement. We have to consider he's in a chronic stage. So we have to consider how much you can change. And I think through the repetition, maybe he can keep a little bit of this during the daily living situation, and depends of the wish of the patient. If you want to improve this, if the person, that doesn't matter if I have an hyperextension in my knee, important is that I can walk, you can't change it. But for me, it was fine. Nice lecture, Marcel.
Thank you.
Thank you, Marcel and Benedict. And now let's move to Fritz. So Fritz, there is a question, says there is a message saying, great lecture. I'm wondering about your strategies and treatment for the first person you presented, the one with Horn and Yahr level 5, with severe spinal structural changes in the cervical and upper thoracic level. I have seen patients with Parkinson's disease with structural changes where they have increased cervical flexion, drop neck syndrome, and it's very difficult to assume neutral posture. Therefore, the patient may have difficulty to utilize appropriate visual stimulus during activities due to their limitation on the cervical upper thoracic range of motion. I saw that you have used scapular patterns to help achieve trunk extension, but I would love to hear more on your take on these impairments and or how you address it during treatment. Thank you.
Mm-hmm. Yeah, thank you for asking this important question. I think mainly, of course, we would like to try to prevent coming these problems in the patient, but for some reasons we cannot prevent it, so we have to deal with it. And we see always the structural changes as a topic in the Parkinson's disease patients. We have the reduction of the mobility due to stiffness of the joints or tightness of muscles. It will be always be visible in the patient. If you look at the PNF techniques, you will find good tools for improving joint mobility or reducing muscle tightness. For example, if you look at the upper trunk flexion position, a lot of patients have that. You can try different techniques and ideas for reducing muscular tightness. For example, hold, contract, relax may be very beneficial for trunk flexors, for pectoral muscles, for neck flexors. You can try rhythmic initiation to reduce muscle tone, to relax the patient a little bit. We can use breathing exercises to reduce the muscle tone and to relax the patients. You use breathing exercises also to improve the trunk mobility. As you could see very nice in the presentation of the Valeo team. Using breathing as a strong part of the body now, it will support the patient in his action to improve the trunk mobility. So you get a better trunk mobility by using breathing, because breathing might be a little bit a strong part of his body. Some techniques to improve the mobility are dynamic reversal and stretch, repeated stretch. So, you can use this muscle activity to improve joint mobility. Now you address the muscles to improve the joints. It is also very beneficial to use all these mentioned ideas on your patients. So try out as a kind of trial and error and have a look what works well. I mix it up a lot of times, do a little bit like this, like that, figure out what is the main problem, where's the main target where we can improve the patients. Yeah. So beneficial positions where you can use this is sideline. I like this very much. You can do a lot of trunk activities, improving trunk, also shown by the Valeo team. Supine may be beneficial, and I use also very often sitting position while the trunk is leaning a little bit backwards. So gravity is helping the patient a little bit and makes it easy to perform, like in one exercise I showed on the video. That's it.
Very good, Fritz. Thank you. Now it's appropriate to move to Jamie because she's going to talk about breathing. So that's good. So Jamie, the first question for you says, a lot of older adults will have limited shoulder range of motion or spinal mobility. For example, increased thoracic flexion with increased cervical flexion extension. Therefore, in supine, they may not achieve the desired range to facilitate posterior rotation of the rib cage trunk extension during inhalation, with or without use of upper extremity trunk patterns. What is your suggestion modification of these patients, on these patients?
Yeah, that's a good question, because I think a lot of times when people attempt some of these activities, they want to do the activity because they think it will be good for the patient, but not necessarily suited for that patient. And I think that's something that we do really well in PNF. We kind of take a look at the whole person, see what they're capable of doing, set them up for success. So with this patient population, you saw an example actually with a gal with the COPD who breathed with her accessory muscles and she had her drop sternum. And so you saw in that demonstration a lot of what I would do, how I would handle it. I definitely wasn't going to go and have her try to lift her arms above head because she would have gotten to about there because of how depressed she was. So if you go back to that example, I chose to use some reciprocals, and even the reciprocals were making her still kind of guard and try to work really hard. So I ended up doing more of a passive and active assisted phase of rhythmic initiation to get her to start to move. So an indirect approach. You know, when I'm looking at someone like this, I think of a really tight knot and I'm trying to unravel this knot. And if I just go to the heart of it, and I'm not going to get anywhere, I have to kind of find the areas where the patient is capable, the little loose threads I can start to wiggle away. So reciprocals would be one idea. Lower trunk rotation, which you saw in Fritz and Ulla's demonstration. I think someone else used lower trunk rotation also. I use quite a bit with my patients for breathing. I even incorporate breathing in with the lower trunk rotation as a very nice indirect approach away from where they're very tight. And if you wanted to go a little bit more direct and try to actually get some more shoulder range of motion, you certainly can use things like contract, relax, hold, relax with the scapula. With some of the, you saw some scapular posterior elevation when I did the mass extension. And so you could just use the contract, relax, or hold, relax just on the scapula to also work that too. So I think the main thing is just remember that you just have to meet the patient where they are and start to get them to move wherever they can. And for me, if I had subsequent treatments with the gal that I was treating, I would have wanted to eventually get back up to that sternum and get her more lifted. But in one treatment, that was not possible. So we have to start where she can have some success. So anything else anybody else wants to say? That's all I have to say.
Thank you, Jamie. So now moving to Benedict. Dear Ben, first question for you. Which are the best effective techniques of PNF to manage muscle tone, particularly about the spasticity of post-stroke?
Easy answer, combination of isotonics.
You would say combination of isotonics.
Yeah, we should emphasize the eccentric contraction, and this is what I like with this technique, because one of our aim should be that the patient can control the muscle. And if I work eccentrically, our assumption is that we get more control from the cortex to the brainstem. And this is the reason, if you ask me, would be for me the best, if you can say, best technique for this kind of problem.
Okay. Somebody else wants to add something, or can I move on?
Fine.
Okay. So now we come back to Karsten again. What do you have to do? What do you have to say, I should say, about the use of PNF in children with learning disability?
So nice question, but perhaps just because I immediately have some ideas. Okay, that means that we cannot make use of cognition so much, and of course in motor learning we have some aspects that is in our list when we talk about motor learning in our PNF courses that are depending on cognition, but there are many, so many that are independently from cognition. So if you look to my lecture, I put some of them together in a group of the emotional needs. So that means, for example, a shaping. So slowly to make the challenge a little bit more challenging, or the task a little bit more challenging. So the patient doesn't need to realize that we slowly make it more complicated, or that we challenge the patient even more. So this is one aspect. Or for example, emotion, of course. Start with a topic or with a task that is easy to achieve for the patient and slowly make it a little bit more challenging, like we said in shaping. And also start with something the patient likes to do. And produce by this some success, so that the patient realizes that he is able to do something. So this word of self-efficacy is, I think, a magic word in the treatment. Task-oriented practice. So it should be something the patient really needs, or in this case, the children is aiming for, like toys or something which he wants to reach. Rhythmic cueing is a very nice thing. I think rhythmic or rhythm is not something that we perceive by cognition. It's something what more is in our brain and we can perceive automatically. Variation, put in some variation. So if the patient is able to do something, then change a little bit the circumstances, the setting of the treatment. That is repetition without repetition, what we always say in our courses. And of course, something very easy. So human beings learn very easy by observation. So go in front of the patient, or in this case, the children or the child, and perform the task you want to work with the patient, and ask then the children to imitate something like this, like in a game. I think that helps. So cognition is a small part, which we very often can make use of, but there are so many things in motor learning, and by that to make use of in PNF, these are not dependent on cognition. Maybe some other ideas of my colleagues.
I would support the idea that the task itself is very clear. Yeah, so like catching a ball is much more clear than giving some abstract commands. Mm-hmm. Yeah, so from the situation, if it's clear what has to be done, that is much, much easier than some complicated things or which are not connected. So I think especially this emotional aspect, having fun, enjoy moving or solving the task or creating a challenge would be really important for those types of patient.
Yeah, stimulate the person with goals outside of the body. This is what Mrs. Wolf says when she talks about external focus of attention. That's much easier than to ask the patient, can you feel in your body, blah, blah, blah. So create some goals outside of the body and stimulate with this. That works.
Thank you very much, Carsten. And it's good to remind that to refer the lecture from the last year online Congress from Agnieszka, even though the kids that she used there didn't have much cognition problems, but there are a lot of examples of task-oriented approach and everything I think is good. And it's still in our platform, so people can watch it. It is very useful. Okay? Mm-hmm. So Marcel, you again. So let's talk about backwards gait. So someone said, thanks for a great lecture. You mentioned that backward walking is generally difficult for patients with neurological conditions. How did you provide backward training, incorporate backward walking with the patient with T4-5 incomplete injury, since it's still an important activity to do? What are you looking for when performing backward walking with your patients? Thank you for answering my questions.
Okay. So the situation I mentioned that backwards gait is difficult was that I was practicing stance phase with it was the hemi patient. I think it was the situation this question is referring to. So I was practicing a stance phase on the affected side, and then it's of course easier for the patient to make with a so-called non-affected side a step forwards and backwards. And then if you like to connect, having like a whole gait cycle, so adding the swing phase or just working on the swing phase, this taking the affected side, taking the foot back, that is very quick, difficult for a hemi patient, for example. Yeah, so this selective movement of hip extension and a selected knee flexion, and maybe the lack of dorsiflexion makes it difficult to get the leg backwards. And then instead of doing swing phase forward, backwards, forward, backwards, like as a practicing situation, it makes more sense to continue the gait, because otherwise the patient gets stuck all the time. So that was the situation I mentioned that. So actually this question is a little bit targeting at another type of patient. So spinal cord, T4-5, incomplete. I mean, to take a step back, you need the lower segments. So it should be not that much incomplete, like something Asia D. So the patient has some selective function and maybe some weakness. And then, of course, it depends. What is the reason why the patient cannot step backwards? Is it just a weakness issue? Then we can, of course, prepare those muscles, having some mat activities like bridging or PNF patterns, if you want to. Extension pattern with a knee flexion, for example, could be useful using timing for emphasis if we just focus on single functions of the lower extremity. And then, of course, in the upright position, we have to try to facilitate that by taking the step backwards. Backwards gait, normally in daily life, if you're not a PNF therapist doing gait class, you don't walk so much backwards, really. So when we walking backwards is usually only 1 or 2 steps. When I open up a door, if I get the trolley out at the supermarket from the line, and then I have to take a few steps backwards, but it's not long distance really. But actually, if it's just a weakness issue, then of course it would be possible to train it like that and slowly integrate it then in a higher level like that. If tone is a problem, like with a hemi patient, it's really, really hard work. Yeah, so to get a selective knee flexion, especially in higher positions, when tone is increasing, these associated reactions are increasing, that then we have a hard time for sure.
Thank you, Marcel. Fritz, there is a question here that I think is more appropriate for you, because there is someone asking how to facilitate turning using PNF technique in partially dependent clients. And this is sometimes a limitation from the Parkinson's patients, right? Difficulty in turning. So perhaps you could talk a little bit about it.
I suppose it's the turning in stance, right? So as a gait.
I think so.
So I think, again, depending, of course, of the state of the patient, but he can walk, I suppose. I would suggest to let the patient hold with the hands somewhere, parallel bars or a wall or whatever, and start turning around step by step. So build it up in small steps, using pelvic patterns in it, but then do more like a kind of braiding exercise. So the crossing steps backward or forward, in whatever direction the patient wants to turn around. We have different kinds of forward turning or backward turning. So maybe you figure out what is the most favorite for the patient, and then practice it with the patient step by step, starting with small steps and then make it bigger. One activity.
Thank you, Fritz, for your answer. Coming back to Jamie again. Jamie, second question for you. It says, what about patients with unilateral weakness? For example, hemiparesis? How would you facilitate breathing, especially with the lungs ipsilateral to the involved side? Would you use more a trunk pattern? What about someone with hemiparesis with significant structural changes in their spine?
Yeah, it's a great question, and we see this all the time. I don't know how used to people are to assessing breathing patterns, but you will see this quite a lot in your patients with hemiparesis, that they are breathing more on the uninvolved side and less on the involved side. And so just placing your hands on the lower or upper rib cage, you can pick this up quite easily. One of the techniques that was demonstrated in the demonstration was timing for emphasis. And so this is one that I am using quite a lot. I can hold back on the stronger side. If I'm on the lower or upper ribs, I can hold back on that stronger side. And then I can use a repeated stretch through the range. And that's a pretty common technique that often will able to elicit the movement and get the breathing pattern to start becoming more symmetrical. So that's probably a favorite one. But of course, you know, doing some reciprocals and adding breathing in with that's kind of nice too, to get just to start getting some more movement on that side. If I'm trying to use the upper extremities to bring in to facilitate some of the breath, of course, if they have a hemiparetic arm, then I have to take care to have the stronger arm to help assist that. So instead of doing the chop or lift, as you saw in the videos, I might have them clasp their hands together or assist the arm to go up into the ranges that I want to get them, as long as they can do that pain-free. So quite a lot of nice options, and I use this all the time. And if my patient didn't come to me with necessarily a breathing problem and I felt like I needed to spend the whole treatment doing breathing, anytime I'm giving my patient a rest break, I am, you know, going in and, you know, we're doing what we call an active rest break, which is maybe not such a nice term, but I'm making them work a little bit also during their rest to try to normalize that breath, because it's also going to help get their trunk integrated into functional activities the way I'd like to, in a more symmetrical way, just by changing their breathing pattern. So.
Thank you very much, Jamie. Now for Benedict again. Dear, if the postural instability is the cause for spasticity, what would be the cause for hypotonia right after lesion of the central nervous system?
The reason is the paresis. After lesion, the central nervous system is not able to recruitate enough motor units, and this is the definition of a central paresis, central weakness. This is the answer. Easy, short.
Okay, my dear. So let's move back again to Karsten.
Just a second, maybe I can
Yes.
to add a little bit, to say we have to consider, especially in the early stage of rehabilitation after a stroke, how we can activate the patient. So how we can get more motor units with PNF through simple activities in order to avoid or to diminish the compensation strategies.
Okay, pretty good. Okay, Karsten?
Yes.
I want to know where I can get the best evidence related to the techniques of PNF.
On our PNF website, IPNFA. So I'm glad for this question, because we can point out that we have a nice website of the IPNFA. And if you go there under literature and open access, on the open access there, you can find many literature articles that answer this question. I recommend highly the one of Fred Smedes, there, where he put many studies together, and there we can see that's a comprehensive concept, and that is a lot of proof, much more than we thought. So we were very happy when we go through this study and this review to see how much proof already we have, but of course we need even more. But I think Leandro can put the link for those articles to the audience. That would be nice. Thank you, Leandro.
Thank you, Karsten. Okay, Jamie, let's go to you again. Third question says, could you talk about the purpose of vibration during exhalation?
Yeah, the way that we were using it is more about tissue compliance to get the exhale, especially on someone who's in a held posture with an elevated sternum, kind of the opposite of the lady that I was describing earlier, but that elevated sternum, and you're trying to get it to drop. So clinically, it tends to work nicely for for tissue compliance, to get the tissues to move a little better. And I'll go back to my knot example. Sometimes when you're trying to loosen up that tight knot and get it to move a little bit better, you do a little oscillation or a little wiggling to try to get things to move a little more. And so we find that clinically. I mean, certainly you can find examples of vibration. Margaret Rood used it both to stimulate muscle and to inhibit. Also, you find it in examples of trying to move secretions. So this also has to do with breathing as well. You can move secretions from lower areas, smaller areas to larger areas for them to get cleared out. So that's another reason you might use vibration. But in the tutorial that we gave, it was all about just getting the tissues to move. And so, yeah, that's kind of why we were using it.
Okay, thank you, Jamie. We move to Benedict again, and later on we're going to have more general questions, and then everybody can participate. But now, Benedict, thanks for your lecture. It says the email, and then it says, during the treatment, you can see the improvement in stability. But more often, when the patient goes home and after 2-3 days returns to treatment, the same patterns of instability appear again. What should we do?
On one hand, it shows us if I can change something during my treatment, 2-3 sessions, that the patient has a potential to change it. But then I had to advise to this lecture from Carsten, Principle of Motor Learning, and then we have to consider how we bring in repetition, training program for the patient. It should be simple, easy repetition, and here is a little bit different. Here I would give really the advice, repetition by repetition and not repetition without repetition, because therefore the patient normally need a feedback from our side. So this is what I do with my chronic patient, that I give them a clear exercise, what they have to do regularly in order to keep, or what they can take it over in the daily living situation.
Thank you, Ben. As I said, okay, sorry.
Please think of, so even if we do not change something in the setting, the second repetition is not similar to the first one, because always the brain now has a little bit gained of experience. And so it's always repetition without repetition.
Great.
You know what I mean? Okay.
Very good. So as I said,
no, that's okay. Absolute fine, Carsten. I want only to give the auditorium the hint that they make it not too complicated.
Of course, absolutely.
They're really easy in the daily living situation, because sometimes my experience is, especially the young colleagues, give them a lot of exercise in different positions. And my feeling says, or my experience is then that the patient is not doing the exercise because they are complicated to make it easy at home. So this is the reason I want to mention this.
Absolutely.
So as I said before, I'll try to keep the more specific questions first, and then we open to these general ones, okay? So I'll think I come back to Carsten again. So it says that number 5, Carsten, it says, making people participate in their treatments when a spinal cord injury has poor gait expectatives is a difficult task. Can you give me some advice about this?
You're right. It's hard to handle this situation if the expectancies are high and the probability to achieve it, or the goal, is not that high. I think empathy is very important then. So as a very first place, that you understand the situation of the patient, and it's easy for us to put ourselves into this position. And there is maybe a very tremendous changing in the life, and then we cannot accept that so soon. Then we can try to put some patient's cognition into the game. So try to, for example, start with easy things like working for alignment of the trunk in an upright position in sitting. So, and then slowly put some weight onto the legs so that the patient slowly understands that when we later on want to work, we need to be able to balance the center of mass on top of the base of support. And so that the patient understands by cognition, what we talked about before, that there are some prerequisites for walking. And of course, it would be nice if the patient by himself understands that he in this kind of hierarchical system of from bottom to up, that he is somewhere in the middle or at the beginning, and that we cannot go for these high level tasks, something like this. So put the cognition inside and try to work with the patient on the prerequisites. And if the patient is able to achieve something, then of course we can put the next step and make it a little bit more challenging for him, like we said before with shaping.
Okay, thanks. Going back to Jamie again. Jamie, could you speak about the dosage of these wonderful breathing techniques you have shown in the lecture? How many repetitions are you doing during a single session? As sometimes doing too much breathing can cause dizziness in patients, and some patients may not tolerate much deep breathing activities.
That's exactly right. And the answer that our students hate is it depends, but it really does depend on the reason why you were doing the breathing treatment. If you're doing it on someone who's very compromised breathing, or in some of the COVID patients, we've actually found that if I have them breathe too deeply, it throws them into a coughing fit. So I have to really ease my way in to a more indirect approach and try to figure out how to get them to breathe and to loosen up the rib cage in a different way. In the literature that I cited in our presentation, they are doing the full treatment of just breathing, and they make reference to this also, that they give patients a 1-minute rest break to return to their normal breath in between bouts of breathing. And sometimes I would see, I think one of the articles suggested 3 bouts of a deep breath and then follow it down to the exhale and then facilitate the inhale. And I find clinically that's about right. I was trying to think of, because I don't know that I've ever counted it. I'm more assessing what's happening in the moment with the patient, but I think that's probably about right. And then I kind of let them return to their normal level of breathing. Of course, in PNF, we're exaggerating it, right? So I let them return to their lower level of just normal breathing before I move on to something else. And of course, if they get dizzy, you're going to do less, have them take less deep breaths, or just return to something else that you know can also facilitate the breathing. Like this is where the reciprocals passively or the lower trunk rotation might be nice to add into there, rather than them having to always take these deep breaths to facilitate the expansion of the trunk. In one of the articles, they were doing this in the ICU, and I sort of got the impression that the rhythmic initiation and the quick stretch they were using seemed like they were just manually on the rib cage as the patient was breathing, but not necessarily verbal cueing a huge deep breath. And so that I found, and what they found in that study was they didn't necessarily get a great result in terms of efficacy of using that, but they did find that it was safe to use in the ICU patient, which was kind of nice to see that you could. They were doing 90-second intervals and then resting in between. So, but clinically, a couple of repetitions, pay attention to what how your patient's feeling, move away, do less direct, deep breathing if you feel like they're not tolerating it. So.
Okay. Thank you, Jamie. So Ben, one more for you. It came to you direct, but there was also in the chat right now, kind of similar question. So they say, the one that was direct to you was, I would like to know about repetitions. How many repetitions are adequate, or will it depend on the patient's condition? And then the question that I was just right now on YouTube, it says, I would like to know about repetitions. Should repetitions be performed according to the patient condition, respecting their limitation, or is there a parameter in the literature?
Ooh, how to say that? First, easiest answer would be depends on the patient conditions. I make it like this. Also, maybe the other guys can help me later with his literature. I spontaneously have no idea. I make it like this, like I know this also from sport training programs. I use 70% of the maximum performance without a pathological pattern. Let's say, for example, sit to stand. Patient is able to perform 10 times sit to stand without associated direction. I would advise him to do this 7 times to be sure that he's not training a pathological pattern. This would be my advice, how many repetitions the patient should do.
Fritz, do you see differently with Parkinson's disease patient or no? Sound. We cannot, okay.
Sorry. Basically, I totally agree with Benedict that you can look at it like a kind of a training therapy, that you say, okay, so many % of a maximum performance. On the other hand, if you look at Carsten's lecture about motor learning, I prefer also a lot of patients to do less repetitions, but do it a lot of times a day. And that is the other option what you can think of in your treatments. Do it this way or that way, or maybe mix it up, whatever you like. So for me, there's no defined way of doing it.
Marcel, want to say something?
Yeah, of course, depends if the patient has a really low level and maybe 10 repetitions are not possible, and then you finish after 2 or 3 or 4, could be like that. Yeah, so we should think also in the other direction. So that is also one limitation, and then still you can go for the 70%, but 70% of 5 repetitions will be a bit difficult. But then when you see the patient is fatiguing and then you don't get any result anymore, or the performance or quality is not good, then of course that's the latest moment you should stop and then do something different and maybe come back again after a while, so there's some recovery, and then try again, and maybe you can do more or maybe not more repetitions like that.
One thing one more time from my side, depends for me also what is the aim of your from your homework, from your repetition. What kind of aim do you have? Do you want to strengthen the patient, or you want that the patient stretch by themselves? So then you have to do it differently, and then if you stretch somebody, he has to learn how to keep this position for a longer time. Then it's not necessary to repeat it 10 times. So also this we have to consider what the patient should train in his repetition.
I think we just kind of touching on a few things that you guys have talked about, but we're having worked with TBI patients, takes a very long time to get an exercise set up sometime. And so that patient, as long as they have the endurance and the quality is not deteriorating, I'm doing a lot more repetitions with that patient. Once they get the idea and they understand what we're doing, we're going to keep repeating that a lot, because to stop and to start another activity is sometimes not very efficient with my time with them. So my treatment plan for them might look like 2 or 3 activities versus someone who has good cognition. I might have maybe fewer repetitions of something, but more activities that I want to get through to get them into the functional integration piece. So there's another, it depends, is their cognition.
And of course, we all are clear, because this is part of our philosophy, that the patient needs to be challenged. So under stress is also not beneficial, because if we want to change the structures, we need to challenge the patient. So this is the other direction. And Monica, we had this question, is there a thing like too much PNF or something like this?
Yes.
That relates maybe to that. And of course, that we can answer very generally. Overuse of structures can of course, cause damage. And so the dosage is absolutely crucial. So, and the dosage is depending on the patient, as we said before. And too much exercises also can lead to a worse performance. And this can can decrease the motivation of the patient. And another view on this question could be that we must be clear that hands-on, on the one hand, supports the patient, or feel him safe, and we can stimulate at the same time. But later on, we need to put the hands off. Otherwise, the whole thing doesn't make sense. The patient should not be getting dependent on us.
I wanted to mention, thank you, Carsten. I wanted to mention, maybe I got the question a little bit wrong. I thought this question belongs to homework. So this is what I mean. If I do homework and I'm not with the patient, then I'm staying with this 70% what I was explaining before. But of course, if I have hands-on in the treatment situation, like we said, Carsten, only to mention this, especially with chronic neurological patients, you have to challenge them. If you believe in plasticity, that we can guide plasticity with our treatment, we have to work at the border of the patient. This is really what I convinced. It's really the idea. And this fits perfect to PNF.
For me, it was not clear if the question was for homework or not, but usually in the courses, participants ask commonly, how many repetitions should I do? And then I think with all the answers, we could clarify this. Okay, so now, as Carsten mentioned, I think maybe we already answered is there a thing like too much PNF should not be used? This is another general question. So it fits with what Carsten started to answer. Is there a thing like too much PNF should not be used? Who else can just...
Difficult to answer, because I would say it depends on your clinical reasoning, depends on the diagnosis, depends on the stage of the patient. Just touch the patient, just give him only a tactile stimuli. It's PNF for me. This is really, I would say, if you overuse the patient with PNF, you did something wrong as a therapist.
Okay.
Sorry, maybe too strong to say this. I don't know what you think, guys.
No, I think that's right. And also, I think it's important to remember that PNF isn't just the hands-on facilitation of a trunk pattern or an arm pattern. PNF is also the philosophy of setting them up for success. So then you do hands-off practice, but you set them up in an environment where they're going to experience success and have them do that. So in that sense, my answer would be, as long as you're not pushing to the point of deteriorating quality or fatigue and that type of thing, then I don't think you can overuse PNF, as long as you understand it's not just about the hands-on facilitation and resistance piece of it, that it's the whole thing. So it's hard to answer because it's hard to know what they're thinking when they're asking that question.
Yes, you're right. Jamie, I have one more question for you specifically. It says the use of PNF for facilitating the breathing pattern and elasticity of the rib cage. Do you work the costosternal joints in isolation at any moment of the treatment? And if the patient cannot use the intercostal muscles, do you passively assist the movement?
So do I work specifically on the costosternal joints? The beauty of PNF is, even though we teach these specific manual contacts, like you saw in my tutorial, but my hands, they can facilitate more specifically or more generally. So we showed you more general hands-on facilitations of breathing. But if I am figuring out that I've got a joint or something that is not moving and it's very isolated and specific, I will put my manual contact there and have them continue breathing. I could switch into, my orthopedic and joint mob and that kind of thing, but I tend not to need that very much. I tend to be able to isolate my manual contact where I'm finding the restriction. And sometimes I will, if I'm trying to achieve the posterior rotation of the rib for an inhalation, I might come underneath that specific rib that I'm figuring out is not moving very well. And I might do some passive movement of it for a tissue restriction. If the issue is they don't have the use of their intercostals, that gets a little bit more difficult. I could come passively and help them, but I've got to figure out also going back to what are they capable of doing? Are they capable of accessing the diaphragm more for the breathing? And then there's where I'm going to focus my facilitation more than, you know, if they don't have access to the intercostals, I can't make that happen. If it's a spinal cord lesion that, you know, they just don't have that. So I have to figure out what I can facilitate in that moment that will actually help them to breathe better. So I don't know if you guys have any other thoughts or with your patient populations.
Okay, thank you, Jamie. Now I have a general question. So I'm gonna ask, it's under Karsten, but anyone can answer or add a comment, whatever. It says, hello, everybody. I'm just ending the basic course in PNF, and I have not so much experience, but have much impression about PNF. My question, is the PNF concept full and complete, and only combinations of basic patterns can change, as in chess? For example, we are limited to certain combinations, or with the development of neurophysiology and science in general, as well as the experience and knowledge of PNF therapists, the basic principles, aspects of philosophy can also be improved and supplemented? What is your vision of PNF concept development?
Yeah, the question is smart and the answer is simple. Also, the first question, yes. So in our courses, we call the patterns very often prototypes or templates. And in many activities, we can find movements that are very close to our patterns. And then we can apply it one by one, so it fits very well. But not very seldom, it's the case that the patterns are just close to the activity. And then this is the amazing thing of PNF concept, that we then have to adapt to the activity of the daily life. And we can play with this, and also with the techniques. Some of the techniques imitate things like sit to stand and stand to sit. So we can make use of combination of isotonics, because we have the concentric, the eccentric, and the static work inside. And then we can imitate activity of daily life. And if we think, okay, we need some more insight here, we can combine the techniques. And this is what was maybe the reason why I sometimes started almost 40 years ago to be interested in PNF and to learn these very flexible concept. That was not me.
No,
Yeah, I often talk to my students about that, because they come out of the courses and they have all these patterns and these skills, and they tend to get stuck in a rut just doing one combination or these things, because they have not developed that creativity and that ability to assess in the moment exactly where the person might need you to put their hands or how to set them up so they can start doing it hands off. And I liken it to when you first learn to play the piano, you had to play scales. But once you get good at it and you start playing around with it, well, then you can riff and play some jazz, you know. So that's kind of the thing to do, I think, is if you're first coming out of a course, you've got to practice, make sure your skills are solid. And then you've got to start playing around with it and really understand that it's about assessing your patient in the moment and what they need.
I think the question was for the development of PNF. And when I look back, when I started to have my basic course and the way how PNF was applied at that time, I would say it's much different now. And of course, as we have new knowledge from research, from evidence-based medicine, of course, we are integrating this kind of ideas, and it will change gradually our way of treating, how we apply the patterns. One question, or the one part of the question, was to combine the patterns. I mean, if you just think, well, you're doing like bilaterals, and of course there are some limitations according to the anatomy. So some combinations are theoretically possible, but maybe not very functional. But in general, look, I think we are developing, we're still developing, and certainly we are not at the end now. And we never know what's coming onto us. And certainly in 10 years or 20 years, we will have different ideas than today. And if we look, we had a couple of techniques adapted. Replication years ago, it didn't exist. And probably maybe there could be some variations of techniques, or somebody invents a new technique if it makes sense. So I think we are open for that.
Everything is said. I have nothing to add.
Okay, and it's nice to think about the IPNFA at this moment, because probably not everybody knows that we have a meeting every year. And in this meeting, we discuss all these topics. We have a instructor day that all instructors and assistants get together, and we develop the topics during the year. And the idea is to update the knowledge, so everybody's teaching an updated concept. So it's nice to know. Talking about the questions, I'm done with the questions. I don't know if you guys wants to say something?
I would like to add one thing to the question before. On one hand, of course, we develop and we are using PNF patterns in a very different way as we did it 30 years ago. On the other hand, it's also very nice to see how new research results fit in this old concept very nicely. How the people who did it in the past were way back in front of us with the ideas they had then in that time, and that you can see a lot of things coming back again, and it's again repetition without repetition, actually.
Perfect. You guys are done also?
Yes. One more time, thank you to all these people watching our videos. Thank you very much for that.
Yeah. Yes, it's nice to say that it was quite a surprise for all of us. My colleagues now can understand this. In 2020, when we decided to make the first IPNFA online Congress, that was not that our expectation was pretty lower than the results we have since the first one. We thought, oh, perhaps we're going to have 500 people. That would be great. And then this year we have 4,000 people, 4,200 people registered from different countries. And this is so nice for us. And then with the second one and now the third one, we hope we can have more and more. And most of the lectures is still in our platform on YouTube, so people can go back and watch them. And so we must thank everybody, all the instructors, all the speakers, and everybody who spent your time and your attention to watch the lectures. So we must thank everyone. Karsten.
Especially one more thank you to all these subtitle makers. So this is a tremendous job, and thank you very much. I know that they had a hard time.
Oh, yeah.
It's very good. Yeah, and opens a huge door, the subtitles. The first year we didn't have a chance to do it, but the second and the third one opened a huge door to many people that cannot understand English to watch the lectures. So thank you to everybody that is participating on this project with us. Okay,
Yes.
and thanks Leandro also for working as a backup on our chat. Thank Lucas, my son. And hope to see you again soon on the next IPNFA Online Congress next year. Okay? Thank you very much.
Thanks a
Thank
lot.
you, Monica.
And see you
Thank you.
soon. See
Monica.
you soon.
Bye.
Bye.
Thank you,
Bye-bye.
Monica. Thank you all.
Ciao.
Bye-bye.